Parenting podcasts can be a bit earnest. Parenting Out Loud is not that podcast.
This person who I may not agree with politically is trying to talk about integrating children, not just into his professional life, but into public life.
I have referred to myself as one and done. That article did make me rethink the term.
It took about 11 seconds for this to go viral.
Oh God, is this the ejaculate one? That is deranged and I love it.
Parenting changes the way you see everything. Parenting Out Loud takes the big conversations of the moment and puts them through that filter.
Because if parents are thinking about it, we're talking about it.
Parenting Out Loud. Listen weekly wherever you get your podcasts.
Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And we've co-opted Erin, our senior registrar, Dr. Erin Stewart.
Is still here in the studio and is going to help us with Q&A.
Yeah, so we said, just hang out. You might be able to impart your wisdom as well. And so it's a 2-for-1 deal, people.
Here we go.
Good. So Erin, how this works is people ring in with their questions. And
they don't ring in. Like we don't have a.
We don't have a phone.
We're not a call-in show. You may not ring.
No, nobody rings in anyway. They go onto a website called SpeakPipe and they leave their questions.
Great.
And then we also get some via our email. Sometimes our program, people doing the Grow My Baby program also leave a question.
Great.
So we've got a couple of those today as well. Also, we had a really great one from one of our program people on secondary infertility. So we're lining up a guest to come on and talk to us about secondary infertility. So if you're listening, that's why your question isn't on this one, but it will be very, very soon because it's an in-depth one that we want to cover.
Yeah.
Great. Good. All right. Well, I'm going to start with this one.
Hi, Dr. Pat and Brigid. First up, thank you very much for your podcast. Absolutely love it and constantly learning new things. So really appreciate it. My name is Emma and I'm currently pregnant. I had a miscarriage earlier this year in June, which was a miscarriage, and I'm currently pregnant again, currently 8 weeks. And I just got back some results from my GP recently, including blood results, urine and a swab, and as part of that swab, they found some Ureaplasma species, and in particular one that's called Parvum. My GP mentioned to me that he had done some quick research, but it's something new that they've only started testing in the last 5 years, and basically that there is some sort of link between Ureaplasma Parvum to miscarriages or infertility. Obviously, because I've already had one miscarriage this year, I'm obviously quite concerned that that could happen again. So very curious to get your thoughts and insight into, the risks and what I should consider and what would be a good next step. Thank you so much.
Good. Is that a good one to introduce you?
It is,
Erin? I just don't even know. What is Ureaplasma Parvum?
Ureaplasma is one of the microorganisms that can be, cultured from the vagina if we swab the vagina and grow it in the lab. And there's a large number of different things that can live in a healthy vagina that we are constantly learning little bits of extra information about, despite knowing for hundreds of years that vagina was an environment rich in microbiology. The questions we got to ask is: there's a lot of bacteria in the vagina, and what's supposed to be there and what's not. What's a disease needing treatment, and what's a bacteria that actually belongs there. And then can these things cause disease? And should we be treating it? Is it possible to eradicate things from the vagina? And so that's the area of research.
Now, Erin, you worked in an MFM unit. Can you tell people, just remind people what an MFM is? We've actually had an MFM on who was one of your supervisors. So just firstly, what is that? And you had something to also impart about this particular issue.
Yeah, so MFM is the Maternal Fetal Medicine Unit, and I worked underneath a range of specialists in that unit, and it was great to learn high-risk obstetrics ultimately, and whether that's mother or baby reasons. Ureaplasma was one that we commonly saw. There is a small increased risk of miscarriage, preterm birth, preterm pre-labour rupture of membranes with ureaplasma, and it was ultimately a area of obstetrics that is still being researched, and probably like the GP said, it's a more new area of research, but ultimately, if ureaplasma was found, it would be treated, and it would be treated with a safe antibiotic called azithromycin. And that was for a range of reasons, but ultimately the thought was that there is greater benefit to treating the condition than leaving it, but there's a lot more space needed to research this area.
So tell me, if somebody is this a normal or a routine swab that somebody would have after a miscarriage?
It's not really a routine thing to do.
Yeah.
It might become one.
Yeah.
If it turns out.
I'm just thinking anyone listening to that will go, okay, well, I want to be swabbed after a miscarriage now.
Yeah. If it turned out that somebody's that the bacteria in the vagina had played a previously unknown, really important role in first trimester miscarriage, then maybe routine swabbing afterwards would become part of it. But it's not current practice. We know that most first trimester miscarriages come down to the enormous complexity of making a whole new person out of half the DNA from the mother and half the DNA from the father. And when those two sets of DNA from the sperm and the egg come together in one big, giant, enormous zip to create the DNA of the new person, that process is fabulously complicated and sadly often goes wrong. And so there are a number of reasons why someone might have a first trimester miscarriage, but the best probably understood is that we wind up with a big long strand of DNA that can sustain a pregnancy till 6 or 7 weeks, but doesn't have the genetic wherewithal to go beyond there. And we might have a very small number that are due to infection, but it makes a lot more sense, for example, that if someone had a really short cervix in the second trimester and was under investigation for that, that really short cervix might not be quite providing the microbiological barrier to the baby that a big, long, closed cervix would have. And so we'd be much more interested in what was going on in the vagina. So then we would swab, we would find these things, and we would say, fine, if it's there, we'll treat it. Yeah.
Are you surprised that a GP did the swab, or would you think that this person now needs to go to an MFM, or what would be the course of her pregnancy now?
I think that now that it's known to be there, I think there's absolutely no dramas in treating it. Yeah. And I'm not aware of data showing how effectively it could be eradicated from someone who currently wasn't pregnant, and whether that would last until they were pregnant again. I guess that perhaps nobody knows that. But you could treat it.
Being 8 weeks pregnant, it's safe to take that in pregnancy?
Well, I think the listener had a miscarriage, is it?
No, she is now currently 8 weeks pregnant.
Oh, okay.
Yes, I believe it is, yeah.
Sorry, that's what I heard. Yeah. All right, Emma, I hope that helps you in it's often sort of just maybe the GP, I've had it before in my own life where the GP sort of throws a line away and that's what you hang on to. You go, okay, GP said that must be really bad. Then you go home and you research it and you think,
Yeah. Look, this raises a good point about, do we treat things just because they're there, or do we need proof that thing is actually causing our problem? Yeah. And then and when we look at something like first trimester miscarriage, people, in my experience, people find it very frustrating that we can often not indicate the cause, And we can often not offer a future course of action other than finding the strength within to try again. And people go, yeah, wow, that's a bit lame. I thought you'd do better than that. So I can understand why someone would want to latch onto this as a potential cause, but to be honest, I think it's most unlikely to be relevant.
Good.
Struggling with the anxiety that comes with adulting?
Or maybe you've suddenly become the parent to your parents.
Wondering if you might have ADHD, but unsure if or how to get a diagnosis?
I'm clinical psychologist Dr. Anastasia Horonis.
And I'm Ashani Dante. We're your hosts of But Are You Happy?
Bringing you all the self-development and mental health information you actually need.
New episodes drop every Saturday morning.
Just in time for your hot girl walk.
So tune in to But Are You Happy? The podcast where overthinking finally gets the spotlight it deserves. Made in partnership with Medibank.
All right. I'm going to read our next question. It's anonymous. Hi. I'd love to know more about blood pressure suddenly dropping in pregnancy, a vasovagal. I've experienced this a few years ago pre-pregnancy, and more recently it happened twice in one day at 11 weeks pregnant. My GP didn't really have any answers other than it can just happen. Thank you. Love the podcast.
Good one. And this is another one where it's a really common phenomenon that we don't have a really clever explanation for. Is that right, Erin? Yeah. These really big circulatory changes happen in pregnancy. It's amazing what happens to the cardiovascular system of the pregnant woman. I find this really interesting. So that even from the start, little changes happen in heart rate and respiratory rate as a result of hormonal changes. And then later on, the amount of blood circulating around a pregnant woman circulatory system is much larger. The stroke volume, how much the heart pumps out per pump, is much larger. And all these sort of things really make some pretty radical changes to the way the cardiovascular system works. And it's not that weird to me that occasionally that leads to some funny things like palpitations and fainting.
Especially, I mean, if she's had that a few years ago pre-pregnancy, is that somebody that just is a fainter?
Well, it'd be good to further investigate them to see if there's a non-pregnant reason as to why they're fainting as well. And I think that's part of the complexity of our specialty, is that just because we're women and we're pregnant doesn't mean that you can't have a whole range of other conditions that also need to be separately treated.
That you came into the pregnancy with that as an issue.
That's right.
Yeah.
Yep. If we're talking about, that's a very good point. If you're talking about someone who's, we take a careful history from this person. We'd say, we're talking about a moment of dizziness when you stood up too fast, or are we talking about falling down and losing consciousness? Because you could have, some severe thing like a complete heart block, an electrical problem with the heart. That could happen to a pregnant person just because they're a person. Yeah.
Good. Well, I hope for you that you have no more vasovagals in your pregnancy and you get through the whole 40 weeks.
Women who are prone to benign vasovagal events have to be careful of them because if we've ruled out nasty things and it's benign. So I do talk to people who clearly get lightheaded on standing, that could lead to a faint which could injure them. So if you get out of bed, if you're toasty warm in bed, everybody's blood pressure is pretty low, and because it doesn't take much pressure to get blood around your body if you're lying down and you're toasty warm, and then suddenly you get out, it's Ballarat morning, you stand up, it's freezing cold everywhere, and then suddenly, so there's you should sit for a moment before you stand, and I also recommend pregnant women, if you're in the bathroom, especially if it's cold in the bathroom, that you set the shower to warm and then heat it up. Because I saw someone once who just got into a hot shower, the temperature changed very quickly, fainted and got burnt.
Right.
Yeah.
Yeah, and also the risk of hitting your head when you faint.
Yes,
that's all right. Well, that went somewhere I didn't expect it to. So yeah, exactly. Just be careful if you're prone to fainting, just to go at a slower pace.
Exactly.
A slower pace, not like an Erin Stewart pace, which is really fast. She goes really fast everywhere. All right.
Hi, Dr. Pat and Brigid. thank you so much for your podcast. I've just discovered it and been listening to far too many episodes for the last couple of weeks. I have a question about viruses in pregnancy. So I am 21 weeks pregnant. Just had a good 21-week ultrasound this morning, which is great. But I am always worried about catching something from my other children. What sorts of viruses do we have to worry about? I know about CMV and parvovirus, but what about sort of other fevers and rashes of unknown causes that toddlers always come down with? It would be great to hear a bit about that.
Now, before we start, we have got this in our Grow My Baby program. We've got a whole bundle on infectious diseases. So, if you're keen to get that sort of information, then I invite you to come along and join us on our Grow My Baby program. But let's do a quick overview. What else should she be worried about? What else can those little pesky kids from daycare bring home?
All sorts of stuff. Yeah. So we've concentrated in obstetrics on the things that are dangerous in pregnancy. So, and I think historically that we've just concentrated on those because the vast majority of the other things, the bugs that kids come home with a runny nose and so forth from daycare or primary school, they are a bummer for the household to have to deal with, but they are not dangerous for pregnancy. Yeah. So the things that we can do is to make sure that before you're pregnant that your rubella vaccination that you had as a child is still working. Get that check, get a booster before you're pregnant if not. We don't have vaccines for CMV and parvo, which is why we concentrate on those two. And, we've covered those in other podcast episodes. And we should be aware of chickenpox as well. A small number of people have neither had the illness as a child nor been vaccinated, and they're at risk of getting a primary chickenpox exposure in pregnancy, which is relevant if they're right at the start of the pregnancy or right at the end, and a pretty big pain in the bum to get in the middle, but not terribly dangerous. And so those are the ones that we concentrate on. Have I left anything out there?
No, that was great. You'll hear a lot of food advice in pregnancy as well, making sure that you make sure you don't eat deli meats, or, you hear this common concept of not changing the kitty litter. So there's other conditions that we worry about like listeria or toxoplasmosis, and it's just really important to adhere to those food safety standards to reduce the risk of those infections in pregnancy as well. What about changing your toddler's nappy? Was there something that I remember someone said that's
changing other toddlers' nappies? Yeah, so that comes up with childcare workers and CMV. Yeah. So that a child with CMV can shed that for a long time. Yep. And if you are pregnant or planning a pregnancy, then a higher rate of care about those things is needed.
Okay.
Yeah.
Yes.
What about RSV, flu? We've got vaccines for those at least.
Yes.
Yeah.
Hang on a minute.
No, we do. No, we do. It's just that that's a little bit different because the way that so if an adult gets RSV, that is not a serious illness for that adult.
Yep.
The reason we're vaccinating pregnant women for RSV is not for them; it's for the baby.
Yep.
So some immunity goes through the baby through the placenta and the cord, and the baby comes out partially immune. And the risk of seasonal flu is also a little bit different. That is bad for babies because mum may become, in a very rare circumstances, critically unwell. Yeah. So if mum's got bilateral pneumonia from seasonal flu and can't get enough oxygen herself, then the baby's not getting enough either. And the worst way that could affect the baby is we might have to say, right, this baby's coming out even if it's not ready, because we can't get enough oxygen into mum to oxygenate the baby. And that was the whole basis of the outcomes in COVID, the pregnancy outcomes in COVID. It wasn't that COVID was inherently dangerous for a baby to get, give or take. It was that the poor old fetus was suffering the effects of mum's severe pneumonia.
Right.
Yeah.
Other things like slap cheek, is that problematic?
Slap cheek is parvovirus.
That's parvo.
Oh, that's parvo.
Yeah.
Okay, good.
Yeah.
Good. What about herpes? I think it'd be worthwhile talking about herpes as well. So toddlers with a cold sore.
People with a cold sore are shedding virus, and we should be as careful as we can be. Again, to get a cold sore on your mouth in pregnancy is more unfortunate than disastrous, because the advice would be not to kiss the newborn, and they're pretty kissable newborns, so that's always a significant bummer when that happens. And then there's it's not as common as one would think, but if you have, in the age of suppressive therapy, but if you've got an active genital lesion, then it's a problem to have a vaginal birth. But thankfully we don't see too much of that, because if someone's prone to recurrent genital outbreaks, you can take suppressive treatment in pregnancy, which is extremely safe for mother and baby, and then you just don't get the outbreaks, and you're almost guaranteed not to have one at term.
So, I mean, you look at your toddler as a bit of a petri dish, don't you? So what are some of the things that people can do? You can't prevent it all, but what can you do to keep yourself safe?
Mostly, I think it's just good hygiene, like just, hand washing is, have a proper thing of proper soap next to all the sinks in your house, and hand washing is probably the main thing. It's such a fact of life for kids to touch each other and share, things, pencils and to give each other infections. It's just
part and parcel
part of being a kid. Thankfully, apart from those named ones, it's very inconvenient to get a bad cold in pregnancy, but not otherwise dangerous.
Yeah.
And we want everyone to love on their toddler like they would normally, but making sure you adhere to safety, like you said, washing your hands, but don't limit the amount of love that you give your child because of the concern that you may have.
Yeah, that's right.
Yeah.
Just maybe don't share their fork if you're if you're feeding them, which I used to do all the time. Like, oh, that looks delicious. I'm going to have a little bit of that. All right, I'm going to move on to this question.
Hi Bridget, hi Dr. Pat. I'm wondering if there is any more information on trying to conceive after a primary CMV infection. I went for my preconception bloods ahead of trying for my third kid. I've got a nearly 1-year-old and my toddler is just over 2, so a bit of a sitting duck with them both in daycare a few days a week. I saw the New South Wales health guidelines recommend possibly waiting up to 12 months, but I couldn't find any information on what they recommend in the UK or the US. I really don't want to wait if I don't have to. We were going to start trying at the end of this month. They've taken another blood test to make sure it's not a false positive, but I'm keen to understand what the next results, could say, whether, it's an old infection or a new one, and at what point would it be fine to start trying sooner rather than later, and at what point should I wait? Thanks. Bye.
Erin, I'm going to ask you.
Yeah,
because you're the closest to probably knowing the guidelines. What?
Thanks a lot.
Sorry, Pat.
I don't know about that.
No, we do know that because we did the same. So, what do you think, Erin? When can she start trying?
Yeah, so it is a really complex question because CMV in blood tests, you can look at previous exposure, so it's called IgG, and then you can look at more acute exposure, which is called IgM, and both will show up in a blood test. The complexity with CMV is that IgM, which can show a new or acute infection, can last for years. So even with the additive information that you've got a positive IgM, it's hard to say exactly when that started in the last few years. There is good testing now that we do keep early pregnancy blood tests for even up to 12 months. So you can get retrospective additional information from blood tests that are held by the lab, and they look at what's called the avidity. And the avidity can tell really the change in the IgG and the IgM over time and whether it is more likely that it's a new or past infection. But ultimately, the guidelines do suggest waiting that 6 to 12 months from the time that you have a primary infection, and that really we'd have to see the blood test to see what that means. But if it is a true primary infection, it's suggested to be 6 to 12 months. Alternative things are that you can continue to get blood tests to see when that IgM disappears, but ultimately that could be quite a long road and it could be longer than 6 to 12 months. It's a hard position to be in, knowing that information, and sometimes when we do know the information, we then have to act on it. And a lot of the time we don't test for CMV as well, is the other thing to take into account, that there are many people that have a very healthy pregnancy and they haven't been tested for CMV and we don't know their status. But I would say ultimately, as a summary, the guideline would be 6 to 12 months.
Probably not exactly the what you wanted to hear, but aren't we glad we brought Erin along? That was
excellent answer.
Excellent answer. Yeah.
So the idea is that from a primary infection, viral load can hang around for quite a while, and could infect a pregnancy long after the woman had recovered from the primary infection, as long as 6 or 12 months after. Yeah. And it is a difficult situation because once you know, you can't unknow it, and you can't give up anything other than sensible advice. I'm hearing from the listener that she wants to get on with this. But some of these things hang around for a while, even after you're well. And if we had good evidence that it was a primary infection, then those guidelines are there for a reason.
Yeah. Good luck with your decision around that.
Hit that arvo slump and fighting to refocus? Everything feels harder than it should. I'm Claire Murphy, and this is Well, your weekly wellness reset. No fluff, no fads, no woo-woo, just clear, expert advice to help you bounce back to your best. So whenever you need a second of self-care, join me and our resident GP, Dr. Mariam, for real talk on our bodies, minds, and how to live a healthier life. Listen now, wherever you get your podcasts.
I'm going to read one now. And I picked this because we often get questions about dating, as in dating the pregnancy, not dating somebody.
That's the wrong podcast.
Wrong podcast for that. Okay, so hi team. I've been listening to your podcast and getting great info for my first pregnancy. Thank you. Most questions I have are answered with your well-informed episodes, but I have one I'd like to clarify. I am supposedly 8 weeks pregnant, but confused about the gestational age and due date. The date of conception, as estimated by the dating scan, was 9 days after my LMP. So we were told a discrepancy of less than 14 days tends to be counted from LMP. I typically have a very consistent 30-day cycle. My GP also said scans showed the baby is a little small for its age, but I don't know what its age is, and has referred us for a subsequent dating scan at the end of the week. I'm confused about what this means and why the 40-week count happens from different times. I'm small. Maybe my baby is just a little small. Any clarification would be great. All right, Pat, over to you.
Look, it's a good question. It's a common source of confusion in people who bother to map the numbers out and go, hang on a minute, that doesn't seem quite right. My understanding is that the idea of a 40-week pregnancy and that how pregnant you were dated back to the days before ultrasound, when the only piece of information we had was the first day of the woman's last menstrual period. And of course, on the first day of the woman's last menstrual period, she's not pregnant at all. And so for that, no matter what your definition of pregnancy having started yet, it certainly hasn't started then. And so for the first 2 weeks of the pregnancy that are counted in that 40, you're actually not pregnant at all. And that's because that's the only place they knew that they could reliably start from. So they meant that a pregnancy would involve 40 weeks of amenorrhea, no periods, but that sperm and egg didn't even come together until the first 2 weeks of that period was up. There are sometimes discrepancies in when people know that they menstruated, know that they ovulated, or know when they had intercourse, and it doesn't seem to match up. And to be honest, it's kind of good to have an accurate estimated due date, because if you're well over that estimated due date, we start to recommend that perhaps we should interfere. So it's nice to be accurate to know that you really are overdue and that the dates aren't wrong.
Mm.
So what I do is if there's an apparent discrepancy, an expertly done first trimester pregnancy scan within the first 8 weeks is extremely accurate. You got to be good at it. You have to make sure you're measuring the right bit of the baby and that they're actually measuring the full length. But it's very accurate, and it's likely to be a better bet than any of the other things which are an estimate.
Because she says, the GP says that her baby's measuring small and that she's small, maybe the baby's just small. But at that gestation, aren't they all about the same?
Yeah. Whether you're very tall or very short, it doesn't matter. Differences from your personal genetics and your cultural background don't come until later on. All human embryos are about the same size at that time of pregnancy development. So that's why you can say that if it's that long, then you're that pregnant.
So her GP's right by saying, let's go and do another dating scan at the end of the week, and then she'll know exactly, what gestation she's at.
Yeah. I think having regular cycles is really important, and it's great that you've got that data there that you can look back on. But, if you've got such a discrepancy, very important to get more scans. Yeah.
The scans will show a consistent growth as well. So if you had one at 6 weeks and then another one at 8 weeks, and the growth between the two scans is about 2 weeks worth of growth, and we know 2 weeks have gone by, then that all fits in. And if those are out, then one of the scans might have been wrong. But if they both show 2 weeks of growth occurring within 2 weeks, then that strongly indicates that they're both accurate.
Great. All right. I think we've got time for one more because both Erin and Pat have to get back consulting. In fact, I think you're running late. So, all right, let's go for one more.
My name is Caitlin. I am not currently pregnant but have been pregnant twice this year so far. My first pregnancy was a missed miscarriage at 10 weeks. My second pregnancy ended just last week at 7 weeks when it was discovered via an ultrasound that I had a ectopic pregnancy. My fallopian tube was removed by keyhole surgery, and I was very unconfident with the decision that the doctors had made because I thought I had an incomplete miscarriage due to bleeding and passing tissue. One key thing that really has stumbled myself and everyone is that I experienced no pain. The pictures of the fallopian tube from the surgery show that it was very inflamed and I had internal bleeding. My question is, why didn't I experience any pain or other symptoms of the ectopic pregnancy, even at 7 weeks? What do I do next time to make sure I can get to it sooner so I don't lose my other fallopian tube? And is there any connection between my ectopic pregnancy and my missed miscarriage? Obviously, my body isn't showing me or telling me when something is wrong. Thank you.
Poor love, I can hear the emotion in her voice.
Yes.
It's a tough time. 2 miscarriages in a row, 1 ectopic.
Yeah, that's tough. That's tough to hear, and I'm sorry that you're going through all of that. Maybe we'll answer the last bit first. I don't think that there's a connection. These really are 2 different things, and what you've had here is a shock and run of bad luck, and we're sorry to hear about that. But when we have a bunch of things happen in a row, it's easy to think that those things are connected, and in fact, there's some sort of broader problem here. But to the very best of our knowledge, a common thing like a first trimester miscarriage happening in 1 month and a common thing like an ectopic pregnancy happening in another month, whilst it's heartbreaking for you, it is not connected events. We would look at the 2 things separately and give advice, going forward based on those.
Do you think she was saying that she was unconfident that it was an ectopic pregnancy?
I think the key part here as well is that the fallopian tube would have been sent off for testing, and that will come back with a histology diagnosis that there was pregnancy tissue. But it's such a hard decision to make in the moment when you're being told about a complexity to your pregnancy, and then that you need to go through surgery. That's a huge thing to have to deal with, and to ask questions or to be unsure, I think, is quite normal. To answer one of the questions that she asked was that bleeding can be a really common part of an ectopic pregnancy, and albeit the pain is also common, sometimes it doesn't happen. It's interesting to hear that there was bleeding inside the pelvis as well and there was no pain. So I think that may not necessarily be the common presentation of an ectopic pregnancy, but bleeding can be as well. But it would be interesting, to hear about the follow-up appointment that they would make.
I've definitely seen many ectopics in my career that weren't painful, and there was nothing thought to be wrong to the point where the woman went for a dating scan 8.5 weeks and they could see the ectopic and blood in the pelvis. And when I did the operation, there was free blood in the pelvis. And the woman still reported no pain. So that is to the point where the most recent one, that was this year, it almost went undiagnosed for an extra couple of days because the woman felt so well. Yeah, and it was just that the story as it was given to me by the referring GP didn't quite add up. That I wanted her to be checked for an ectopic, and sure enough, there was. And it was interesting when she went for her ultrasound, even the ultrasonographer was unconvinced that it was a bleeding ectopic because she wasn't even tender. But, it was one of those situations where if it looks like this, that's probably what you're looking at, So as Erin said, there should be no real doubt about whether it was an ectopic or it wasn't. I understand the listeners' concern because, aren't ectopics supposed to be painful? Maybe they've got the diagnosis wrong. No, some are not painful. And the pathology test on the tube should settle that discussion once and for all. We've done some discussion on the podcast about ectopics before, and one thing I think is of some consolation to people is that sometimes people imagine that only having one tube is going to reduce their future fertility highly significantly. Perhaps I think maybe it's 50%. I've only got one tube, I'm only half as fertile, and of course it doesn't work that way. And if the other tube is normal, future outcomes are good.
So I think she's one step ahead and she might have been one step ahead because she's already listened to our ectopic episode. So if you're in your first trimester and you haven't listened to that episode yet, I really recommend that you go back and listen to that. But she's saying she's worried about what to do so she doesn't lose the second tube.
Yes. So that's a little bit of a complex question in that having an ultrasound early on when she's pregnant again will hopefully identify a pregnancy within the uterine cavity and not in the other tube. And that'll be really reassuring. Relax about it. It's not another ectopic. Let's carry on.
So what week would that be at?
You can reliably see some evidence of a pregnancy within the uterus around 5.5 to 6 weeks, and then shortly thereafter, an actual fetal pole with a heartbeat. But in very keen people, we can look even before we can see the heartbeat and at least see a convincing sac within the uterus, and say, rightio, that looks like it's growing in the right place. Let's have another look in 7 to 10 days, and the complexity comes in that if you do get another ectopic in the other tube, it may or may not be possible to fix that in a way that saves that tube. So people say, if they get to it early, can it save the tube? And there's some complexity to that, but at least it won't rupture if we know it's there.
All right. Well, that's all the questions that I brought this week, which is good. As I said, you're already running late. Let's go. Thanks, everyone, for giving us your attention for this episode. We appreciate all your questions and all your feedback. If you want to leave one of your questions for us to cover on the SpeakPipe, you just go to speakpipe.com/growmybaby. But better still, we'll just put a link in the show notes so you can just directly link onto it. Or you could go to our website, which is growmybaby.com.au. All right, everyone, thank you so much for joining us. Keep safe, keep well, keep growing your baby, and we'll see you again next week.
Thanks for listening, everybody.
Bye for now.
Hey, even though Dr. Pat is, well, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.